So this is essentially it was designed as a phase 1/2 study. I worked on this with Dr. Courtney DiNardo and on the lab side with Dr. Michael Andreeff. This is a phase 1/2 study which looked at Milademetan in combination with low-dose Ara-C, low-dose cytarabine, with or without venetoclax in patients with relapsed refractory acute myeloid leukemia with wild-type TP53. As everyone in the field knows that Milademetan, which is an MDM2 inhibitor, it has been studied preferentially in patients with wild-type TP53. So we use this combination. The phase 1 was essentially to look at the recommended phase 2 dose, which was the expansion cohort. 16 patients were included in this, in the phase 1 cohort. Unfortunately, across the different drug levels, we did not see good response rates. Only 2 out of 16 patients had a response, which was a CRP, complete remission with incomplete platelet recovery. And another 2 patients had a blast reduction by more than 50%. We did see some noticeable GI toxicities, but there was only one dose-limiting toxicity at dose level +2, which was considered as the upper limit of dose. Now, it is important to mention that all of these patients were heavily pretreated, and almost all of them had prior venetoclax exposure. So as a result of which, we are looking at a group of patients who are already super refractory. We are doing, again, correlative studies to see markers of response amongst, though there were few responders, but we are trying to figure out what defines a better possibility of response in these patients. And also with the risks that exposure to MDM2 inhibitors increases the chance of a TP53 mutated clone. We looked at the expression of mutated P53 through IHC in some patients. So amongst these 16 patients, we had 11 patients at baseline, the IHC of P53 expression, all of them were wild type. And at follow-up, we had for 7 patients, and we found 1 patient who had received around 2 cycles of the combination, went on to develop abnormal P53 expression, and that was also discovered on the NGS as a low VAF TP53 mutation. None of the other patients had on follow-up NGS any new TP53 mutation. So that was important. However, the median number of cycles on the study was pretty low. It was around 1. So it's difficult to mention whether we need patients to be on many more cycles of this regimen to expect a mutated TP53 clone to be selected. So this is a very early data, I must say. We could not do the phase 2 because the responses were very low with the phase 1. So though the trial was designed as phase 1 and phase 2, we presented only the phase 1 data.